Okay, so if any colleague would like, I think we all of us try to rush and stick to the 10 minutes time given or less than that to accommodate. But I'm first of all grateful to Professor Ashutosh Kumar who helped chair the session. Also very grateful to all the colleagues who presented. If there's anything you would like to speak or ask each other, uh, the floor is open. Also grateful to Professor Nitish Thakur who was here for a long time, and then Professor Bhramar Mukherjee has joined us. She'll be speaking next. Professor Bhramar will be also keen to hear from you. Probably you heard a couple of project uh, spotlight presentations. So the floor is open. Um, like to hear from anyone who would like to speak. Also, just to set the context, these were uh, like spotlight presentations on work that faculty members had been doing here already, but which have now got the next level of support through a seed grant at KCDH. Um, so these were like spotlight presentations where a combination of the work they've been doing and how they're going to take things forward using the seed grant, right? That was presented. Though work has not really begun on the seed granted proposal itself. Yeah. Professor Brahmer, would you like to share anything?
No, of course, I just heard a couple of presentations, and it's just wonderful to see the dream of digital health and nanomedicine and translation of technology into medicine and healthcare being realized. And we all know this is, hard process. Our discoveries in the labs take a long time to reach the patient. And I can tell you, like, in my 25 years of career, one or two maybe are reaching a patient, and that's very lucky. And we spend all our life doing science, but to see the translation potential and to be able to help a patient is the most meaningful thing. And so it's wonderful to see that conversation and that dialogue, and of course the KCDH taking a leadership role in propagating that spirit at IIT Bombay and also nationwide.
Thank you, Professor Brahmer, for the words of encouragement as well as caution, I would say. I think in your words, you also cautioned us against being impatient in this process because from the lab to the practice, the operational setting could be a hard grind.
Yeah, yeah. It's a long journey from bench to bedside, and we all know that. And science is supposed to be hard. It is not supposed to be every discovery makes it to the patient care. So we have to be very patient, but we have to keep on working on that dream.
Thank you. Thank you, Professor Brahman. If there's anyone else would like to comment, please feel free. Otherwise, we are super excited to hear Professor Brahmer speak next. So, anyone
I
else?
don't think I can share my slides.
We will just let you be the presenter. Are you able to present now? Can you share now?
No. It says you are an okay. I think that takes a while. Yeah.
Professor Pramod Pangikar will be chairing the next few sessions. Is that correct, Rashmi? Okay. Yeah,
Yeah,
I'll
he's
just read.
joining.
He's
He's
just joining.
joining.
Can you see my screen?
Yes, very clearly.
Okay. And my slides?
Yes, both.
Okay. All right. Cool. Yeah, I'm happy to start when you are ready.
Rashmi, would you like to advise? Okay. Yeah. So, Dr. Bhramar, maybe a couple minutes. Um, this session
Yeah,
got
no worries.
over sooner. It's, this interesting that most of our sessions are today are getting over sooner than planned. um, I know that doctors are hard pressed for time, and maybe their collaborators here at IIT Bombay are also realizing the value of time.
Professor Ganesh and team, I just want to congratulate. Can you hear me? This is Barnali.
Yes,
So
Dr.
I
Bhattacharya.
heard all the yes, I heard all the presentations, and I really appreciate the efforts and for Koita Center of Digital Health, and many congratulations for taking this leadership role in digital health transformation in India.
Uh, Thank you very much. We take it as encouragement, but I think the honestly the lot of the wishes and congratulations are for the digital health partners, the doctors who have patiently sat with collaborators here, articulating problems and identifying the potential solution between two disciplines which are hardly met in India, right at the ministry level we have Ministry of Health and
Absolutely, absolutely.
Ministry of
And
Education, I mean Human Resource Development, which are two different silos. So I'm really
yes,
excited and grateful that all of you sat together and wrote these proposals. So I would say it's a big milestone. Thanks, Dr. Banali.
thank you.
I think uh, he's joined already. Okay, I can see. Has Pramod joined? Smita? We can probably get started then. Pramod has joined. Since we are waiting for a few minutes for Professor Pramod, uh, Dr. Brahmar, one question I have for you. Um, since your talk is about electronic health records, it's a more data question. Um, how has been the drive for open source EHR how has it been received in the US? I mean, in India, the challenge we face with open source is that you need solution providers, even with open source software, right? On the other hand, the private partners can deal with the problem end to end, but then issues like interoperability and all those creep up, and also the issue of serving the marginalized, right? The really small hospitals, which you
Yeah.
really won't buy an expensive EMR system for 50 beds. So how has this open source been received in the US? I'm very curious.
Yeah, so I think the problems are very similar in the United States as well, that it is a selection bias. People who have good established electronic health records, in particular, Epic is very popular. Um, and but if you go to underserved communities, even federally qualified health centers, they do not have much of an electronic health record. So at University of Michigan, and I'm going to talk about this problem as we are trying to diversify our cohort and make sure that this is a nationally representative sample, it's really, really difficult if you have such disintegrated electronic health record systems like we do in the United States as well. So I think that it is very um, restricted right now for to like Kaiser Permanente. So some of the companies which are vendors of data have lots and lots of amassed a lot of electronic health records, but again it's access to healthcare. It's a very selective population. Where can you generalize your results to? That's something that you really, really have to think hard, and that's one topic that we have been working a lot on. But I do think that if you even look at COVID, the countries which have made real contribution are UK, Israel, Denmark, where they have population-based registries and connected, integrated health records, right? So one from the time you get vaccinated to your breakthrough infection to your clinical outcome, these are all linked in the same system. So you do not have to go that extra mile, so that different kinds of databases are in silos and they don't cross talk with each other. And in the United States also, it's not the ideal system at all. These disintegrated data systems are not really helpful to respond particularly to an acute health crisis like the one that we are experiencing right now. So in Israel, it's very interesting that they have Clalit Health Services, which is a insurance company, but it has 90% coverage. And they have always been very proactive in terms of using data for research. And that's why they could tell us like the waning effect of the vaccine, the need for the boosted dose. It's a small country as well, but still having really comprehensive capture of all the health encounters of an individual is really, really important to do anything population based. You're absolutely right. What we are doing is just like tip of the iceberg and wrinkled with many, many problems.
Thanks, Professor Prabha. That was very, I would say, very nicely summarized, and kind of echoes some of the observations we have in India.
Yeah.
Probably now, without further ado, can request Professor Pramod to chair the next session, and we are keen to hear you.
Thank you.
Professor Pramod.
Yeah, thank you, Dr. Mukherjee, for joining. I understand, Ganesh, that there is a introductory video about the speaker, so we can start.
May I request to Professor Bhramar, can you please stop your screen sharing so that I
Okay.
can share my screen?
Okay. Oh, I didn't know that. Sorry.
Thank you.
I think I stopped sharing.
Yeah. If my screen is visible. There is some problem.
Some of the perils of online conferences.
So, Professor Pramod, I would like to request you please go ahead and drive the session. Professor Pramod.
Professor Pramod, you can get started. Looks like there's some problem.
Yeah. So I was relying on the video, and therefore, Dr. Mukherjee, I must apologize that I don't have a written introduction with me. But let me say that Dr. Mukherjee is a renowned professor in the Department of Biostatistics at University of Michigan. Most importantly, she is on the advisory board of the Koita Centre for Digital Health, KCDH. KCDH is a brand new center at IIT Bombay, focusing on digitization of health using artificial intelligence, machine learning, and so on. We have seen your blogs, and we have heard your views on TV, on NDTV, and so on. So most of the people who are in this session, they know about you quite a bit. So without further delay, I request you to start your lecture, and we'll take questions at the end.
Yeah, thank you so much, and thanks everyone. Can you see my slides? Okay.
Yes, we can.
Okay. All right. So as it was mentioned that I have been working a lot on COVID and particularly COVID modeling in India, but today I'm going to take some time to discuss my research on integrating electronic health records with several other data sources at Michigan and building a source for digital health research. And the resource is not just for me, but for generations of researchers at University of Michigan and beyond. But before I begin, I really want to congratulate IIT Bombay, the collaboration between the Department of Biosciences and Bioengineering and the Koita Centre for Digital Health. There is this dream of using data and technology to improve patient care and human health that we all share. And the intersection of math and engineering and science with medicine, and where people come together, describe the healthcare challenges, and then use technology to solve those challenges has been one of the most fascinating journeys of my life. As a statistician, really trained in pure math in Indian Statistical Institute, I never thought that I would be a part of precision health at University of Michigan. I'll be leading cancer control and population sciences at a cancer center. So it has sort of feels like a fairy tale for me as a math nerd trying to really solve problems in medicine. But this has been the most gratifying journey of my life. So I want to really congratulate you on that. I also want to pay my respect to Professor Banerjee. And this conference, I realize, is in her honor. And of course, she shared the same dream of taking science and innovation to make a difference for inclusive healthcare accessible to all. And we have a lot of important role to play in this process at a national level and at an international level. And I really feel very sorry that we lost such an eminent and promising researcher to post-COVID complications. When we count the deaths of COVID, we really cannot quantify the losses due to COVID. And I just want to take a moment for all of us to think about all the dear ones that we have lost and all over the world. So she had a dream of realizing nanomedicine and translating technology into practice. And when I began at University of Michigan about 15 years ago, which sometimes in life you have to work on projects which are not going to bear immediate results. And that's very hard for junior faculty because we want to see immediate payoffs in terms of our research. But sometimes you have to think about legacy and you have to think about helping others and creating bigger dreams and bigger resources. And that's what this project is about. And I just want to make 2 points how we work towards growing a integrated digital health ecosystem at Michigan with different types of data. And then when COVID hit, how we use these data resources using the EHR data to write some important papers and observations about Michigan residents during the time of COVID. But before I begin, I really want to thank my team. My team is comprised of geneticists, statisticians, epidemiologists, because you cannot really do this alone. One person or the skill sets that we are trained with is not enough. And that's why I'm really excited for the Koita Center, because you are bringing many minds from many fields and many disciplines together to sit at a table and to discuss a problem. And everybody has their own way to looking at the problem and own tool sets to contribute to the problem. So we started about 10 years ago, and we are supported just like, Koita Center is through the generous donation of many important donors as well as support from the institution. We started with support from the Provost's office at University of Michigan. It was about $100 million investment, thinking about creating a data resource that is not just one person's data resource. It's not for a prostate cancer investigator. It's not for a cardiovascular researcher. It is for everybody on campus who can use this data resource as an accelerator and incubator for their ideas. So this database could be used to validate some findings that they have in their own study, but also to generate new hypotheses in an agnostic way. And the ultimate goal was that once we create this resource, people will be able to apply for funding, garner extramural resources in order to keep this legacy going on. And that was in 2012 when we started going to patient clinics. And in particular, when patients were waiting for surgery, we went and asked for their consent to participate in this longitudinal biorepository, which we call the Michigan Genomics Initiative. And this Michigan Genomics Initiative asked the participants to get their consent to connect their electronic health information, which are generated every time you see a healthcare provider at Michigan, with biospecimens that we collected, and in particular, in this case, blood samples, so that we can do germline genotyping. And so and this consent was really the progressive and game-changing transformative piece of this study, because we also asked the patients that, well, you are giving us permission to connect your electronic health records to your genetics, but can we also possibly link this database to other things which can be linked through your social security number, which is like the Aadhaar card number in India. So and that was huge. And I will tell you, people really agreed to give this kind of data. We hear a lot about privacy and confidentiality in healthcare, but people are still willing to contribute to their data to improve healthcare of their next generation. So when we asked for this consent, we also got recontact permission. So that enabled us that given this data, if there is anything, a new issue, we could invite these participants to a new study, or if we find something clinically that is meaningful for their personal health care, we can get back to them. So there are many, many big data resources in the world, in particular UK Biobank, which is a very democratized big data source where you have 500,000 people with imaging data, with genetics data, with health smart device data, lots and lots of different domains of data accessible to everybody in the world. But Michigan Genomics Initiative is very close to my heart. It's very close to my heart because I know this physician, I know this participant. And so the opportunity of taking something, a scientific finding or a clinical finding or a data finding, taking that and getting it back to the community was very motivating and empowering and inspiring for all of us working on this project. So Michigan Genomics Initiative, or MGI, I'm going to say is definitely big data. It has many medical encounters digitized, and then genetic data. And after imputation, we are about at 21 million genetic markers across the human genome integrated with many medical records. But as you will soon realize that an individual or a participant's health existence is not really codified through medical phenotype and genetics, so we collected many other domains of data. And this is something I want to really emphasize. If somebody is trying to create these data repositories or biobanks, it's extremely important to collect data on behavior and lifestyle factors, environmental factors, social factors, because this constitutes the tapestry of our existence, not just our health records and genetics. On a subsample of people, we also have Apple Watch data in a collaborative study with Apple. So then I felt that while using this data, it was not enough to just have the medical diagnosis at each encounter codified as an ICD or International Classification of Disease Code. It was important to have questionnaire data or survey data, and we launched an epidemiologic questionnaire study on top of this layered architecture of different domains of the data that we showed you. And then physicians, if somebody is interested in cancer, so we provide this broad T-shaped umbrella of data to everyone. We do not really need to ask a patient 100 times during their interaction that their smoking behavior, their alcohol consumption. We just can ask in a same data definition these questions. So these questions are available for everyone, but if an investigator is interested in mental health or cancer or pain outcomes, then they have their own deep dive questionnaire into that specific disease domain. So this is our thinking, that we'll have lots and lots of things measured on many people, but then we'll have the opportunity to deep dive into a particular disease area. For me, for example, GI related cancer or women's cancer. So what we have created over the last 10 years is this database, which has genetics, electronic health records, but also I told you that we could connect through social security number any medical claims or pharmacy claim data, national death index, any kind of outpatient EMR. And then also, because we had geocoded residence information, that's where, data modeling tools come in. Because we had the residence information varying over time, we could connect that to get some ambient measures of air pollution. We could get census tract variable on neighborhood characteristics. Do they live in a neighborhood which has access to healthy fruit and vegetable stores? What is the average income in that neighborhood? So we could collect a lot of ecological level variables based on their geocoded residence information. So at the end of the day, over 10 years, I really have a dream data set. And when I graduated in 2001, I never imagined that from my desktop, I'll be able to access data on 100,000 people on so many millions of records. And that dream has been possible through information technology advances, which has been really, truly a revolution in our lifetime. So when we have all of this, when an acute public health crisis like COVID hits, then we can layer this data with additional COVID data. And that's why you have heard me complaining a lot on television about the quality of data. We do not have integrated health systems, and United States is far from being perfect. And I'll give you some examples which I think have been great role models. If you have all of this data in Michigan EHR, at least that we were able to layer it with vaccination data, COVID severity, who are getting hospitalized, who are experiencing long COVID symptoms, and then we are able to roll out several surveys in the beginning part. We also realized that during COVID, obviously surgery nobody, like a recruiter was not allowed into the healthcare spaces, but we still did not give up. We actually recruited patients by phone and sent them saliva kits so that they could send their sample back. And you can see that it's important to continue our research in spite of the difficulties that the current times are posing to us. And then the epidemiologic study was also rolled out during COVID. And it is amazing that this was a period where people actually like to do surveys, and particularly about health. So our completion rates on surveys were very high. Just think about it, during lockdown and stay at home, we are playing with our phones anyway. So we are more contributing to the process of survey research. And that was a great time to roll out this survey. We also rolled out several surveys on COVID. Many of you know that worldwide, the Facebook and many other organizations have done repeated surveys on COVID-related symptoms. But for us, because we had an engaged participant community, when in May to June of 2020, in the very early days of COVID, we could write papers which are truly focus to the people we serve in our catchment about Michigan residents. What are their risk perceptions? What are they feeling about community exposure? What kind of symptoms are leading to severe COVID outcomes? We did not know much about COVID at that time. We desperately needed to gather more information and more data. And in the first few phases, we are really concerned about the bias in the data, because if you remember, tests were not abundantly available, so very few people could get tested. So before you analyze the data, it is very important to understand who is in your sample. Only people who got tested could be diagnosed or have a positive COVID positive record in the electronic health records. So we really tried to understand who is getting these repeated tests for COVID, RT-PCR test, and then later on rapid antigen test, but also to understand the pattern in terms of serological testing or antibodies that are present. And this is pre and post vaccination antibodies have sort of a different meaning, but we continuously model the data coming out of the EHR and try to get that information out there for physicians as well as for Michigan residents. So electronic health record data, it is exciting. It has a lot of like spurious association, lot of garbage information in it, and you have to be very careful analyzing it. But you can see that it has an immediacy that what is happening, what is the action in the medical world. And you can see that in real time, and that was the exciting part of this data. So what I'm showing you on this figure is a figure of what is the proportion of people having antibodies starting from April of 2020 and then after vaccination started. Many times people try to use this as seroprevalence as a estimate of how many people in the population actually had COVID, because we know that there are many COVID infection, many asymptomatic infections, but then you have to account for who is getting tested. But what you can see, in spite of the bias, that there has been a clear change in terms of the proportion of reds and greens before and after vaccination. And it was very exciting to see when if you remember the first days, the excitement of getting vaccinated, that actually the proportion of positive antibodies was actually the fraction of red is increasing. And you can, so what I'm trying to say is that on an absolute scale, there are many anomalies in this data, but on a relative scale, you can still pick up some signals. And that's my biggest lesson, that don't give up, look at the data, use the best tools in your arsenal to make it useful and to make it useful for people. So electronic health record data, and as it was mentioned, it's very porous, it's very spotty. Physicians actually do not like electronic health records. My clinician friend says that when I'm actually talking to a patient, having to input all of these codes at the same time simultaneously in their medical records is very challenging. This data set was this system, or the EPIC system that we use, was mostly designed for billing purposes so that the hospital administrators can send you a bill. I recently realized that lawyers also look at EHR to find out if any medical malpractice was done. Oh, you were supposed to get this medicine at 6:37 p.m. and you didn't get it, things of that nature. But data scientists and informaticians like us really like imperfect data, because then we can show our skill sets to say we harmonize the data, we make it to use so that you can translate the findings into knowledge and in sometimes, rarely, into actionable knowledge. So the challenges with electronic health record data is that the pros are that patients are coming to healthcare system, so you can definitely get the data. So in 10 years, we have a cohort of 100,000 people. You also have longitudinal tracking naturally, because people who are coming for their patient care, primary care at University of Michigan, many of them have been coming there for years. So you have their trajectory. you also have this callback potential of really making a difference. If I find that somebody has a very high polygenic risk score for colorectal cancer, maybe I'll do that colonoscopy more often, or maybe I'll do one type of screening if I knew that this person was at a high genetic risk. So there is that real translation potential, which is really exciting. But the cons are, who is in your study? There is no study design because these databases were not designed for population-based research. So it's a very selection bias prone database. And then when do you see any electronic health records? Obviously, you don't get a blood test done, at least in the United States. The insurance is not going to pay for it unless you have symptoms. So the observation process, when you see these observations, are extremely informative and biased, and you cannot just think that these are random observations that you are gathering on random participants. So that ascertainment bias really makes it difficult to generalize the result until you work very, very hard. So when we teach statistics, we go into our classroom and we ask students that when you think about translating from statistics to parameter or sample to population, you have to ask these questions: who is in my study and what is the target population of inference? And many times I'm seeing that people are getting very jazzed by machine learning and neural networks and all of these deep learning methods, but not thinking about these fundamental questions about what is the population that is being represented in a data set that you gathered from Google or Twitter sentiment analysis, or you are doing electronic health record analysis or medical claims analysis. Who is in your population? So in Michigan, it is a genomics initiative. It's a huge problem because if you remember, I said that we recruit most patients when they're waiting for surgery. And who undergoes surgery? It's not a representative of the whole population. And if you look at the data, you actually see that roughly 50% of patients actually have a cancer diagnosis. So obviously that's not the lifetime prevalence of cancer in Michigan population. This is enriched for cancer. And you'll see a lot of enrichment for other diseases as well. But what is really startling to me that 75 to 80% of the people that we approach actually give consent to use of all of their data, linked through social security number, callback potential, participate in future studies. And you know, when we talk to these participants in community engagement studios, they tell us, we believe University of Michigan researchers, we believe that they are going to use our data to do something good. So this faith in scientists is extremely important in people, and we have to honor that faith as we manage the data, analyze the data. We have to really honor the participants. So what I'm trying to say that if you collect data like this, for example, in Tata Memorial Cancer Center, for example, then you have to think about who is your patient population. And are you trying to generalize the result to a population who are approached for consent from which you drew your sample, or you want to do something bigger? Do you want to go to Michigan medicine entire population, not just the perioperative population? Do you want to talk about the state of Michigan? Do you want to talk about United States? So in order to do that change, to make that extension, you really have to work hard. You have to work hard to understand how does your population that you have, that you are analyzing, differ from the Michigan medicine population or the United States population. And there are ways in which you can calibrate your estimates, but for that you need information on your external population so that you can map. So our dream for this database is really that Michigan investigators have access to a very rich data set with large N or a sample size and large P, different domains of variable. And many people, it's not somebody's property. Everybody on campus, if they have an idea, they can use this database. And that's why the social and the environmental components of the database becomes very, very important. And as we see new crises emerge, we can pivot this existing system to address emerging challenges. But at the same time, we should be really aware of the pitfalls that science is hard. We cannot just take and amass data and analyze it mindlessly. So I'd just like to spend the last 5 minutes talking about how we used it for COVID-19 research. I already showed you that we are very interested in modeling who got tested, serological prevalence, and so on. As I was mentioning, that data is very important, integrated data systems. Some of the pioneering groundbreaking papers in COVID during COVID times have come from the United Kingdom, Israel, Denmark. All of these countries have very good population-based registry or the national health system and very active and agile official statistics department. And so to have this uh, really enabled them to talk about vaccine effectiveness. If I ask in India that compared to like there you have 2 or 3 vaccines rolled out, then what is the rate of breakthrough infections? How does it differ between men and women? This simple basic data is not there. We do not have even disaggregated age and sex level data for mortality in India. So having integrated databases where secure databases are not siloed, where the testing database talks to the CoWIN database, talks to the clinical outcome database, so that you can tell me that what are the rates of breakthrough infection between, Covishield and other vaccines, right? So I, as a consumer, I'm entitled to know this information in a real-time way to decide on my booster. So for COVID, because we had done all of this machinery, we could fit models and just let us, for example, take a logistic regression model. We are trying to model COVID-related outcomes, for example, severity in COVID, hospitalization, ICU rates in COVID, as a function of what is influencing this. Is it race? Is it socioeconomic status? Is it pre-existing comorbidities? Are people with type 2 diabetes or heart disease at a higher risk of COVID-related severities and deaths? If you have to remember, in the beginning part, we did not know much. We only had the data at hand. And from the very beginning, we were recognizing that the loss of COVID, that the distribution of loss of COVID is not uniform across race ethnic groups. There are people who still do not have access to tests and antivirals. As we see that COVID is nothing, we are really talking about, again, a very selective population. So our group was one of the first few groups who wrote this paper characterizing that Blacks were at a much higher risk of COVID-related complications, and that disparity has not been washed away over time. What do I mean? Like in March to June of 2020, in our initial analysis, we saw that Blacks have a higher odds ratio of ICU admission and mortality compared to whites in our database. And if you adjust for certain confounders, for example, socioeconomic status, neighborhood access, then this difference actually diminishes, but still it persists. But then when we looked at January to May of 2021, 1 year later, what we saw that the risk of hospitalization, the risk of ICU admission has gone down. So you can see the height of the bars from the left side to the right side has gone down substantially. But it has not gone down at the same rate for Blacks compared to whites. If anything, the disparity on a relative scale is more acute. It is important to use data to make such social commentaries, to understand and to really underline the inequities in health. And I think scientists can play a huge role in making inclusive healthcare possible. And similarly, we did really machine learning data agnostic searches because we did not know any better who is at risk for COVID-related complication. So again, you have to put these results in the light of we did not know much. We are just taking a blind look at EHR to see who is getting hospitalized. And we see that if you were at high risk for pneumonia or respiratory diseases, of course, hypertension, renal disease, then you are at higher risk of hospitalization. And these risk factors actually differ across whites and across Blacks. And it's important to really characterize such subgroup specific effects. And then we wrote this paper and make this tool accessible and updated our data so that physicians could look at real time. If you had some diagnosis in your past electronic health records, maybe you should be under higher watch or alert for COVID-related complication. So later on, there have been many papers. But to do this in real time when this crisis is going on really takes this infrastructure that you're building with KCDH, which is going to pay dividends in the future to changing healthcare. So right now, we are working on many projects using the EHR. Particularly, I'm very interested in long COVID. Who are the COVID long haulers and what are they experiencing? And we also are looking at how do we think about missing data in this electronic health record? As I told you that you are seeing certain tests because you have certain symptoms. How do we really debias the data from those design issues? And one thing which is really important is to think about the effectiveness of boosters. For the next 2 years, we'll probably take our fourth dose or fifth dose. Are we ready? When should we time it? Like here, you can see the dashed line is the case curve, and in the background in different colors are the variant distribution. And we know that the vaccine effectiveness changes with respect to the variants. And then how do we quantify if a booster is effective for a person, and what are the optimal time windows of getting boosted? These are very important questions, but if you do not have the data, which has your vaccination related with your covariates, related with your COVID outcomes, you are never going to be able to do this research. So infrastructure is really at the heart of brilliance. And similarly, I think that, missing data, I see a lot of missing data work being done by computer scientists and informaticians without paying attention to the basic fundamentals of informative missingness. And I do think that there was a recent JAMA piece by my colleagues saying that really when you do EHR-based research, you have to really assess the missing data patterns, because when you see an observation, it's actually very informative. So I think that as a summary of point 2, I just want to mention that it was very important that we had the right tools at the right time, and also right team. Statisticians and in general quantitative data scientists have a lot to offer in major public health and healthcare issues with their nimble data analysis. Working with electronic health record data was fun, but it could be very frustrating at some during some points of time. But you have to bear through it. You have to persevere. That's our fundamental lesson in doing scientific research. But it's fascinating in the end when you see things that make sense emerging out of this very haphazard, very messy database. So I just want to conclude by saying that I'm a data dreamer, but I'm not the only one. Many people have joined us. I run a summer program where we have trained about 250 students. They come and destroy the electronic health record database, crash the system with terabytes of data, but they are fearless, but they are my hope. If I ever dreamed of a data revolution, this is my army that I'm training. And I hope that along with the mission of creating infrastructure, you never forget the next generation, which has been a real strength of IITs in general to produce the best and really bring people together. And I know that Professor Banerjee was also a very keen mentor and very devoted to her students and trainees. And that's the main legacy of those of us who are in education, not just research, really building strength through the next generation. With that, I just want to thank you for your attention and also thank each and every participant of Michigan Genomics Initiative, without whose contribution and sharing of data, this research would never have been possible. Thanks so much.
Thank you, Dr. Mukherjee. I know that the video didn't play well in the beginning, the introductory video, but the students have, worked hard to prepare the video. So we are going to try it one more time. Is that okay, Ganesh?
Absolutely. If
Yeah,
Dr. Bhramar is
go ahead.
fine.
Yeah.
Ladies and gentlemen, we are delighted to have with us Professor Bhramar Mukherjee, who joins us from University of Michigan. Professor Mukherjee is a John D. Calfus Collegiate Professor and Chair at the Department of Bioscience, Professor at the Department of Epidemiology and Global Public Health at University of Michigan, School of Public Health. She is also a research professor and core faculty member at Michigan Institute of Data Science, University of Michigan. She has completed her PhD in statistics from Purdue University in 2001. Professor Mukherjee and her team have been modeling the SARS-CoV-2 virus trajectory in India for the last 1 year. Her research interests include statistical methods for analysis of electronic health records, studies of gene-environment interaction, Bayesian methods, shrinkage estimation, analysis of multiple pollutants. Recently, she has been interested in shrinkage estimation and prediction using diverse heterogeneous data sources. Ladies and gentlemen, please join me in welcoming Professor Bhramar Mukherjee.
I'm sorry, Professor Bhramar, for this technical error from our side. So what I guess is that that PPT was containing heavy video files, so that is why that got stuck all of a sudden. So I'm very sorry for that.
Yeah, so we can open the floor for questions. If people can raise their hands, then we can go in that order. Yeah, I see Professor Nitish Thakur has raised his hand. You have a question?
Yes, sure. This is great, very informative. And in fact, the last point about long COVID is going to probably play an increasing role, as also these booster shots,
Yes.
take them or not to take them with new variants. Do you have any opinion on whether it's even possible to build predictive models? I mean, because past may not apply to new variant, and so what's the biostatistics of these kind of predictive models that are going ahead?
Yeah, this is very interesting question, because with the different variants, we are sort of at a different risk profile. So what we have seen so far, and from not just my work but review of the literature, is that definitely post vaccination, and also like it's very hard to tease apart like the effect of the variant and the vaccination, because most samples we have is vaccinated and the variant has also changed. So what we see is definitely that the probability of getting past post vaccination have gone down. But once you get it, the duration and the complaints and the suffering is very similar, and the symptoms that you have is very similar to the past. So we just published a paper yesterday in Journal of Infectious Diseases that globally, all of the studies that have come out in the last 2 years, the prevalence of PAS in COVID positive patients is about 40%. And for hospitalized patients who had to be hospitalized, of those conditional on that, it's about 50%. And this is worldwide. And this is huge, because there are studies which have also come out that asymptomatic people who did not feel anything, there is 10% PAS incidence there too. So this makes you very concerned about this, 30% to 40% of COVID positive patients have lingering complaints. 50% of those hospitalized had lingering complaints, and 10% of those who are asymptomatic had lingering complaints. So that makes you estimate and project that 200 million people, 200 to 400 million people is all over the world are probably struggling with this. So I think that we have to have dynamic prediction models. That's why I think EHR and getting the real data is very, very important. And that's why I showed you the variant distribution, as well as the curve, the surge, that when do you get vaccinated, when do you do booster. So I do think that prediction models are helpful in order to understand that what are the disease mechanisms and the pathways through which PAS can happen, what diseases put you at higher risk, but the probability of getting PAS is definitely going down. It's more to understand once you get PAS, like what was in your disease history that made you more prone. Yeah. But it's very complicated. Yeah. And also, till last October, there was not a clear definition of PAS. There was the clinical case definition of PAS was only provided in October 2021 by WHO, which says that you have certain array of complications within 2 months of COVID diagnosis and which lasts for at least 3 months. That's now the clinical case definition, and we have an ICD code for PAS. But previously, different studies were coding long COVID in very different ways. So it was very heterogeneous phenotyping across the world. What is long COVID?
Ganesh, you have a question?
Yes, Dr. Bhramar, I was very happy to hear you emphasize the importance of getting basic statistics right, given all the hue and cry about deep learning and with lots of data. Though I thrive on that area. So, but I'm happy to be bashed up on this. I was also especially wondering, like you talked about selection bias, I've also seen this projection bias, which is maybe you alluded to it, maybe I missed it, but that results from restricting the data to records that must conform to certain schema. So I mean, often in many places people are now relying on audio input, free form input basically. The tone contains a lot of information sometimes. So what are your comments on that? I mean, it also kind of alludes to multimodal input here. But then basic statistics might fall insufficient, right? So any comments on this?
No, I am not trying to really undermine machine learning methods. In my work, I do use a lot of advanced machine learning methods, but I think that sometimes we just get jazzed by just the method without thinking about what is the clinical question are we trying to solve? Who is my population? And this thing of focusing the data, for example, I have seen many analysis where people just take EHR and then focus on the complete people on whom you have complete data on this variable. And that's so biased because particularly for a lab measure, you are not going to get this blood test ordered unless you have certain symptoms and certain disease history. So I see more and more people forgetting about how data are made. And so I really want people to pay attention to how data are made and what is your inference question. And then obviously these relationships are not simple. So using a linear regression or a logistic regression often is not enough. You need to incorporate nonlinearity in the feature space, interactions in the feature space. So I'm totally up for machine learning methods. But after adjusting for the right kind of sampling, right kind of selection bias, right kind of confirmation bias, and I do think that the multimodal data presents a lot of challenges because you restrict it to a subset on whom you have all of these components of data, right? And so definitely, and confirmation bias, I think which is probably related to projection bias, it depends on your a priori thinking. So how can you make it create standard elements that everybody is going to follow? Harmonization of the phenotypes across electronic health record system before you merge them. Michigan electronic health records may be very different from the one at Fred Hutchinson. So how do I really combine them without paying attention to this? If I just get data and get very excited about the tools that I learn, you're only going to produce garbage information out there. And we have seen a lot of that during COVID, even with all the drugs that have been claimed to work just by mining the different databases, but they don't work.
That's very helpful. So I think in addition to the point you made earlier, right? First sanitize the make sure that you have sane data, and that could mean that you restrict yourself to tabular data, and thereafter you can open the field, create plugins basically for unstructured data as well. Maybe that's the summary of the message as I understand.
And the unstructured data is much more complicated, particularly for Michigan. We want the data to be usable for many people. It's very difficult to scrape off personal health identifiers. PHI information is most often there. So you have to have very specialized privilege to use those data, which are in voice messages or in clinical notes. We work only very high level security clearance will give you access to that data in Michigan. So it's very important to come up with standardized elements on method of extraction of there is a lot of papers in medical informatics now in extracting, say, data and content from images or pathological reports so that everybody sort of uses the uniform denominator. But still, that getting that data does not really address the problem. You only have this data on a selected population. Is that the only people you are interested in talking about? Or are you trying to talk about a broader population? You have to address that.
Thanks. Very helpful. Thanks a lot, Professor Bhramar.
Shivli, do you have a question?
Yes, yes, I have a question. Yeah, Hi, Professor Mukherjee. Yeah, hi. Very interesting and informative talk. I'm always learning something new from you. So I am very interested in this integrated data system because as I understand, only this disease counts not going to help. You need, like you are saying, official statistics, ecological data, social. So how? So you said US didn't have an integrated, data system. So how did you go about?
No, so we do have integrated data system in the sense that we do have the Michigan records all integrated. But the advantage of UK or having a national health system is that suppose I'm going to University of Michigan today, tomorrow I'm going to a nearby hospital, St. Joseph's, which is a local hospital, or Beaumont in Detroit, for another reason. But there is no linkage of all of these data together. So I'm assuming that when I'm not seeing an observation in Michigan health system, nothing is happening. But a lot of things are happening, which medical claims give us a more comprehensive capture because every time you see a doctor, you have to pay in the United States. So that is more captured. But a single EHR does not give you a comprehensive description of a patient's health history because you're missing many things because they are going to seek healthcare in other ways as well. So there are many solutions right now for United States. So, in UK, everything is in the national health system. So you can get a comprehensive capture of everything that's happening to you. Where are you getting vaccinated? When are you having your COVID positive test, say post vaccination? So you can say, what is the rate of breakthrough infection very easily. But in United States, it's not possible because I may not report my vaccination, which I got at a CVS pharmacy, right? So there will be very lots of missing data in a single EHR. And so we do not have that integrated data system. We are doing as best as I can, but I think we need to do better. Countries where all of the health encounters are captured. So I was very excited when the government was talking in India was talking about digital health ID so that all encounters are registered in a single database, including, your COVID testing, COVID vaccination, and then post-COVID healthcare behavior, right? So that's very important. Right now, we are doing a study where we are looking at people who had COVID, whether are they seeing doctors more frequently by comparing their pre and post COVID period. In order to this kind of studies, you need the longitudinal comprehensive data of what healthcare used to be. And so if everybody's all kinds of transaction with the healthcare system and encounters are captured in the same database, that's what I mean by integrated health databases. Because we don't have that, then we try to say, okay, this is what we have. Then in order to talk about whether this will hold in United States or in Michigan, in the state of Michigan, I need to do some survey weight adjustment to make my population look more like the population of Michigan or the population of United States. But that's not the ideal one. Having really national level, nationally representative data set. If you think about the sequencing data from India, it's really biased from certain locations. It is not a nationally representative sample. And the way we have set up sort of our data and machinery is that we get more of the data from urban, very privileged people who go to Apollo, who go to Max, who come to University of Michigan, and then the voices of those who are unheard continuously gets unheard. And it really accentuates the disparities in healthcare because they have no representation in the papers that we are publishing.
Understand, yeah. Very serious problem. Thank you.
Thank you. So, in the interest of time, we will have to.
I think there is another question from Dr. Das.
Let's take this last question, Dr. Das. A quick question and a quick answer, please.
My question, excellent presentation. My question is regarding the clinical validation of EHR data. So you mentioned about antibody testing in the slides. So here, what like in India, in hospital kind of setup, what we observed, like we see a lot of harmonization challenges between kit to kit. Even in the same hospital setup, we may be using 2 different kits or 3 different kits, and this antibody testing data is showing different results. And along with the post-COVID MIS or multi-system inflammatory syndrome, in many of the cases is showing like COVID antibody positive. So because of that, what challenges you face or we can face like in future for clinical validation of EHR data?
This is extremely important, and that's exactly why I think that our data scientist or a quantitative scientist sitting down and talking to the physicians is extremely